Thank you. Who would like to give us the first question? As you're thinking them, I just want to reflect that working in the UK, we're trying to go paperless and we still can't. We can't mobilise volunteers like you can mobilise in the low-income countries. And we are also trying to think how we can manage people better at home. So all of the presentations were close to my heart and my brain was working. And how actually do we translate what you're doing over there into the UK? So I'd be interested in chatting to you all later. Who has any questions? Yes, there's one here in the front. Thank you.
Sabrina, I'm Paul Mee. I'm at London School of Hygiene and Tropical Medicine, but until recently I was at the WITS Agincourt DHS site, so very interested to see what you're doing. What I was wondering, maybe you could reflect on this, is whether what your results on the use of the mobile phone lead towards is perhaps a hybrid system where you're still using conventional, perhaps mobile-based rather than paper-based collecting of your regular visits, but you serve the telephone as because one of the big challenges in the DHS is the stuff that you miss between visits, and maybe this is the ideal way to address that with more regular contact with the households between the visits, and also potential cost saving of perhaps not having to visit the households quite so often as well.
So would you like to answer?
Okay. Exactly. Right now what we do is we have quarterly data collection. So between the quarterly data collection, health workers are not going to the communities. So one of the bias though is these are the health workers that have had contact with the family, so they know that this health worker is calling. And so, for studies where that trust hasn't been built, that relationship hasn't been built, maybe you see a different results. You have to think about that. But also, I think the result calls for a hybrid system. For many households, it might not be necessary to visit other households, and we have natural calamities during which traveling to places becomes problematic, and we sometimes had to not collect 1 quarter full of data, which is problematic. So a lot of problems can be solved with mobile phones, but then we have to worry about death and birth. These are absolute events. Everybody knows in the family about them. But as we saw in terms of migration, and there are other health and demographic data that we collect which are more sensitive, this might not be a way to go. So we have to think about where it's applicable and where it's not.
Thank you. Any other questions from the floor? Yes, thank you. Do you have a question?
Yes, just one quick follow-up on the same Bangladesh study. It seemed to me your study design eliminated the possibility that you might detect extra deaths or extra events in the telephone part of the exercise compared with the original interview. I mean, surely that's also possible. There could have been some missed events in the interview that were picked up in the phone as well as the other way around.
No, it was the other way around. Well, for deaths and births, there were not like 1 or 2 deaths or births were missed by the telephone. Mostly household visits, it was picked up. But in-migration and out-migration suffered because a lot of these migrations are based on marriages happening. Yeah. And so, for example, if you call someone who did not approve the marriage, the daughter-in-law is living with them, but they don't want to report it because this is not an approved daughter-in-law, right? So they will not report.
No, but it's the other way around I'm interested in. I mean, there could have been events that were reported in the phone interview that were not reported in the visit.
Yes, there were some in the in-migration and out-migration, but not during births and deaths.
But your design didn't allow you to see that?
Yeah, we saw this as well.
Thank you. There's a question up at the back, just on the left-hand side. Thank you.
Thank you. Chantal Foyer from One World UK. I have a question regarding the study in Madhya Pradesh. Did you look at performance increase or decrease, like in terms of the reporting? So did community health workers feel more motivated at the beginning or at the end? Or were you able to look at that? Like, is your data sufficient? Thank you.
Yeah, I think what we did is first, because we piloted this the whole system for we gave sufficient time to set up the system. So we did pilot in 82 villages, and we were looking the call center response. So initially it was less. It started with 20%, 40%, and it went up to 68%. But the thing which we did is our research field was in regular contact with these key informants, and they call them like once in a week. And then if they think that, because we have a quota of deliveries which we should get from that particular cluster or the village, so that if there was less number of deliveries coming from that particular village, we called the key informants. But overall, we didn't get any decline during the whole year. But the only decline which we saw is in the later part of the project, when we have finished most of the quota, and then we were struggling to get 1 or 2 deliveries in the village. But overall, it increased. And also one thing which we make sure that the incentive which we give it should reach them on time. So that is like within the next week they got their incentive for reporting the delivery.
Was it Mobi Cash?
It was cash.
Through mobile phones or no?
No, it was just
cash.
delivered by.
Okay.
So you need reinforcement and incentives, and then you can keep the activity up, as he answered.
And there was one more thing which I want to mention, because we have a teaching hospital, which we also have a medical school. And what we did is, because we can't tell everyone to come to our medical school for delivery, but we can. There was something was there, so that if there is any referral is coming or something is coming, so we have a channel to solve their problem, these key informants. So in that way, it helps us to get required calls.
Thank you. We've got a couple of minutes left for the last few questions. So there's, the one on the left at the top, and then one down here. Thank you.
I am actually from Nepal, but I'm just now residing in Scotland. So I'm very interested in these 2 papers from Vishal and Sabrina. I have a question for Vishal. One, how did you said that you have missed some information about the deliveries, and you said that you sent your community health workers for confirming about the missing deliveries. How did you do that? How did you verify the missing deliveries?
So what we have, we had it we have selected 153 villages, and we have a team of around 7 or 8 male, female, you can say field assistant, and they have their schedule, like in which village they will go, like this week or next week. So once we got a report from the call center, we give that to our surveillance team, and then they went house to house, and then they verified the deliveries, and then if they found a new delivery, they report back to us.
All right. No, I thought that you said, because those who were reported, they phoned to your call center and reported that, okay, this delivery has taken place. So who did not report, so probably you did not have the name or list of the people who are pregnant?
Yeah. So, but what we did is, the job of the surveillance team was to find the missing deliveries. So they went to the village again and to find.
So they went house to house?
House to house, yes.
All right, thank you.
Thank you. So there's one question just down here.
Hi, I'm Sandeep Ghosh. I'm from the India team in BBC Media Action. Just one observation and perhaps a question to you. is, mobile-based or telephone-based research or collecting data had become very popular in India over the last 1 decade. So much so that the regulatory authority came down on us like very heavily. I mean, there are so many restrictions that has been put into the entire process right now. You can't collect personal information, you can't collect geographical information. If the telephone service provider is collecting that information from you, they don't share anything but basically from where the number has called in from. And there's a lot of issues in terms of getting informed consent, prior informed consent. If you're going to conduct a survey, you have to apply for a toll-free number, so they actually see the number and they have the option of exiting or not replying to your phone. So I was just wondering, is your system mandated to take consent beforehand, or is there no such regulation, archaic regulation really, in Bangladesh? Or how did you overcome this?
Who would like to answer?
Okay, so we have 2 large DHS sites running, and usually households that we enroll in the DHS are followed up over a long period of time. And we definitely, they definitely provide informed consent. And this is research purpose. So many of the health and regulatory framework that is in existence for mobile phone-based data collection, in many cases are relaxed for research purposes. And we have to clear ethics and all that. The committees look into what we are trying to collect and all that. The other thing is that we are not collecting there's no data being passed through the mobile phone. It's a phone call to ask, has there been a death in your family in the last 4 months? If so, who is it? And so on and so forth. So basically we just collect the vital statistics from the families that we visited, say, 3 months ago or 4 months ago, just to get an update of what's going on with birth, death, and migration.
Thank you. Okay. I think Ed, drawing it to a close. Yeah, being given clear instructions. I'm afraid I've got to draw it to a close because lunch is waiting outside. I'm sure the speakers will be outside milling around, and so you can all meet with them. And so I'd like to just thank everybody, the audience and our speakers, for an excellent morning.